Lock simulation 24. Same process, fresh set. Read the command phase, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. Which factors increase myocardial oxygen demand and how do anti-anginal drugs help? A patient with stable angina is treated to reduce the heart's oxygen demand. A physiologist reviews the determinants of myocardial oxygen consumption. Read the command, factors increasing demand and how drugs help. Heart rate, contractility, wall tension, beta blockers nitrates reduce them. Myocardial oxygen demand consumption is determined by three main factors: heart rate, contractility, inotropy, and ventricular wall tension. Wall tension itself, by the law of Laplace, increases with higher ventricular pressure rate after load and radius preload volume, and decreases with wall thickness. Anything that raises rate, contractility, or wall tension increases how much oxygen the heart needs, which provokes angina when supply is limited by coronary disease. The correct answer is B. This explains anti-anginal therapy. Beta blockers lower heart rate and contractility, directly reducing oxygen demand and prolonging diastolic coronary filling. Nitrates cause venodilation, reducing preload and thus ventricular volume and wall tension, the main anti-anginal mechanism. Calcium channel blockers reduce afterload and contractility. The strategy is to reduce demand fine, all-core, and unimproved supply. The heart rate, contractility, and wall tension determinants of oxygen demand reduced by beta blockers and nitrates are the answer. What is the diagnosis and why does squatting help with TED spells? A 6-month-old infant has episodes of sudden cyanosis TED spells relieved by squatting. Exam: a harsh systolic murmur and a single S2. Chest X-ray shows a boot-shaped heart. Echo reveals 4 defects: pulmonary stenosis, right ventricular hypertrophy, an overriding aorta, and a ventricular septal defect. Read the command, diagnosis, and why squatting helps. Cyanotic TED spells relieved by squatting, boot-shaped heart, 4 defects. Tetralogy of Fallot, squatting raises SVR, reducing right to left shunt. This is tetralogy of Fallot, the most common cyanotic congenital heart disease beyond the newborn period. The 4 components, remember, ROV, pulmonary stenosis, right ventricular hypertrophy, overriding aorta, and ventricular septal defect. The pulmonary stenosis is the key. It obstructs flow to the lungs and drives blood through the VSD from right to left, bypassing the lungs and causing cyanosis. The boot-shaped heart on X-ray reflects the right ventricular hypertrophy. TED spells are episodes of worsened cyanosis. The correct answer is E. The squatting maneuver is the classic clue. Squatting, or the knee-chest position, INC, reads a systemic vascular resistance, the afterload on the left side. This raises the resistance to the right to left shunt through the VSD, so LES deoxygenated blood crosses into the aorta and more blood is forced through the pulmonary valve to be oxygenated, relieving the cyanosis. So squatting works by increasing SVR to reduce the right to left shunt. The 4 defect cyanotic lesion with squatting relieved TED spells is tetralogy of Fallot. Which pairing of lipoprotein and its function is correct? A biochemistry student studies lipoprotein transport. Each lipoprotein has a distinct role in moving cholesterol and triglycerides. Read the command, which lipoprotein pairing is correct. Chylomicrons, dietary fat, VLDL, liver triglycerides, LDL cholesterol to tissues, HDL reverse transport. Each lipoprotein has a defined transport role. CHY low microns are made by the intestine and carry dietary, exogenous triglycerides and cholesterol from the gut to tissues. VLDL is made by the liver and carries endogenous, liver-synthesized triglycerides to peripheral tissues. As VLDL unloads triglyceride via lipoprotein lipase, it becomes LDL, which delivers cholesterol to peripheral tissues. LDL is the bad cholesterol because high levels deposit in arteries. HDL performs reverse cholesterol transport, picking up excess cholesterol from tissues and returning it to the liver, the good cholesterol. Correct answer is C. The directionality is the key. LDL carries cholesterol, OUT, to the periphery and into artery walls, atherogenic, while HDL brings cholesterol, BACK, to the liver, protective. The relevant enzymes: lipoprotein lipase clears triglycerides from chylomicrons and VLDL, LCAT esterifies cholesterol and HDL, and the LDL receptor clears LDL, and the LDL receptor clears LDL. The chylomicron dietary fat, VLDL liver triglyceride, LDL cholesterol to tissue, and HDL reverse transport functions are the correct pairings. Which list correctly identifies retroperitoneal structures? During trauma surgery, a structure located behind the parietal peritoneum retroperitoneal is injured. A surgeon must know which abdominal organs are retroperitoneal versus intraperitoneal. Read the command. Which list is retroperitoneal? Sad pucker structures. Retroperitoneal structures lie behind the parietal peritoneum against the posterior abdominal wall. The classic mnemonic is sad pucker, suprarenal adrenal glands, aorta and IVC, duodenum, the sigmoid or peritoneal, kidneys. Extem first part is intraperitoneal, pancreas, except the tail, which is intraperitoneal in the splenorenal ligament, ureters, colon, the ascending and descending portions. The transverse and sigmoid are intraperitoneal, kidneys, esophagus, lower thoracic, abdominal part, and rectum. Correct answer is C. This distinction matters surgically and clinically. Retroperitoneal organs can bleed or have pathology that presents with back flank pain and may be missed on a standard peritoneal exam, e.g. retroperitoneal hemorrhage, pancreatitis, AAA rupture. Note the partial structures: the second fourth duodenum, the pancreas except its tail, and the ascending descending not transverse sigmoid colon. The SAD pucker list of suprarenals, aorta, IVC, duodenum, pancreas, ureters, colon, kidneys, esophagus, and rectum identifies the retroperitoneal structures. Which is gastric and which is duodenal? Two patients have peptic ulcers. Patient A has epigastric pain that worsens with meals and improves with fasting. Biopsy may show H. pylori or chronic NSAID use, and there is a small risk of malignancy. Patient B has pain that improves with meals and worsens 2 to 3 hours after eating, or at night. It is strongly associated with H. pylori and is almost never malignant. Read the command. Which is gastric? Which duodenal? A worse with food, malignancy risk. A gastric. B better with food, benign duodenal. The relationship of pain to food is the key discriminator. Gastric ulcers, patient A, cause pain that worsens with meals. Eating stimulates acid that irritates the ulcer, so patients may eat less and lose weight. Gastric ulcers are associated with H. pylori and NSAID use, often with decreased mucosal protection, and they carry a small but real risk of malignancy, so they should be biopsied and followed to healing. Duodenal ulcers, patient B, cause pain that improves with meals. Food buffers acid and recurs 2-3 hours later or at night. They are associated with H. coli. Pylori in nearly all cases an excess acid and are almost always benign. The correct answer is A. Memory aid: gastric ulcer pain is greater with food and weight loss, while duodenal ulcer pain decreases with food, weight stable or gain. The malignancy point is high yield. Gastric ulcers can be malignant and need biopsy, whereas duodenal ulcers essentially never are. Both are strongly H. pylori related. The worse with food malignancy risk gastric ulcer versus the better with food benign duodenal ulcer is the distinction. Which set of definitions is correct? A physiologist measures lung volumes and capacities by spirometry with helium dilution for the volumes that cannot be exhaled. Read the command. Which definitions are correct? RV, air after max exhalation, not spirometry measurable. Farsi, RV plus ERV TLC all. VC TLC TRV. The lung volumes and capacities have precise definitions. Tidal volume is the air moved in a normal, quiet breath. Residual volume RV is the air remaining in the lungs after a maximal exhalation. It can never be exhaled, so it cannot be measured by spirometry alone, requiring helium dilution or body plethysmography. Functional residual capacity, FRC, is the volume left after a normal, passive exhalation, equal to RV plus the expiratory reserve volume. Total lung capacity, TLC, is the sum of all volumes, the maximum the lungs can hold. Vital capacity, VC, is the maximum air that can be exhaled after a maximal inhalation, equal to TLC minus RV. The correct answer is B. The key conceptual points. Any capacity that includes the residual volume, FRC, TLC, cannot be measured by spirometry alone because RV cannot be exhaled. Vital capacity inspiratory reserve plus tidal plus expiratory reserve volume, minus RV. These definitions underlie the interpretation of obstructive disease, high RV and TLC from air trapping versus restrictive disease, all volumes reduced. The RV after max exhalation, FRC as RV plus ERV plus, ERV TLC as all volumes, and VC as RV definitions are correct. Which pairing of DOAC, target, and reversal agent is correct? A patient with atrial fibrillation is started on a direct oral anticoagulant, DOAC, instead of warfarin with no routine monitoring needed. Read the command. Which DOAC pairing is correct? Dabigatran, thrombin, idarucizumab, dexabans, factor exa, and dexanet. The direct oral anticoagulants, DOACs, fall into two mechanistic groups. Dabigatran is a direct thrombin factor, IA thrombin factor, IA inhibitor. Its specific reversal agent is idarucizumab, a monoclonal antibody fragment. The exa-ban drugs, rivaroxaban, apixaban, edoxaban, are direct factor exa inhibitors. The name exa-ban embeds the target. Their reversal agent is annexanet alpha, a decoy factor exa. Unlike warfarin, DOACs have predictable pharmacokinetics and do not require routine coagulation monitoring, no INR checks. The correct answer is A. The naming is a built-in memory aid. Exa-BA factor, exa inhibitor, rivaroxaban, apixaban. Dabigatran is the odd one out, hitting thrombin directly. The advantages of DOACs over warfarin are no routine monitoring, fewer food-drug interactions, and rapid onset. Warfarin remains preferred in mechanical valves and severe renal disease. The dabigatran, thrombin, idarucizumab, and exa-ban factor, exa and dexanet alpha pairings are correct. What is the diagnosis? A 70-year-old man presents with fatigue and recurrent infections, CBC, anemia, neutropenia, and thrombocytopenia, pancytopenia, with some abnormally shaped cells. Bone marrow is hypercellular with dys-blastic changes in multiple cell lines and ring sideroblasts. Blasts are increased but less than 20%. There's a risk of transformation to acute leukemia. Read the command. Diagnosis: older adult, pancytopenia, hypercellular dysplastic marrow, A20% blasts, AML risk, myelodysplastic syndrome. This is myelodysplastic syndrome, MDS, a clonal stem cell disorder, typically in older adults and after chemotherapy radiation. The defining paradox is INE-effective hematopoiesis. The marrow is hypercellular, busy making cells, but the cells are dys-plastic, abnormally shaped and dysfunctional, and die before maturing, so the peripheral blood shows cytopenias, anemia, neutropenia, and thrombocytopenias, anemia, neutropenias, so the peripheral blood shows cytopenias. The marrow shows dysplasia across multiple lineages, often ring sideroblasts, and increased blasts that are still LESN 20%. The correct answer is B. The two key contrasts: aplastic anemia also causes pancytopenia, but with a HY hypercellular empty marrow, whereas MDS has a HY hypercellular but dysfunctional one, and the 20% BLAST threshold separates MDS blasts under 20% from acute leukemia 20% or more. MDS can transform to AML over time. The cytopenias with a hypercellular dysplastic marrow and increased, but under 20% blast, with risk of AML transformation, defined myelodysplastic syndrome. Which organism is responsible? A 24-year-old sexually active man presents with painful urination and a purulent urethral discharge. Gram stain of the discharge shows gram-negative diplococci inside neutrophils intracellular. Some patients develop septic arthritis or, in women, pelvic inflammatory disease. There is no vaccine, partly due to antigenic variation of its pili. Read the command. Which organism? Urethritis with purulent discharge, gram-negative intracellular diplococci, no vaccine, pili variation. Neisseria gonorrhoeae. This is gonorrhea caused by Neisseria gonorrhoeae, a gram-negative diplococcus. The diagnostic gram stain clue is gram-negative diplococci located inside neutrophils intracellular. In men, it classically causes a purulent urethritis with dysuria and discharge. In women, it is often asymptomatic but can ascend to cause pelvic inflammatory disease and infertility. Ectopic pregnancy. Disseminated infection causes a triad of septic arthritis, tenosynovitis, and dermatitis. Newborns can get gonococcal conjunctivitis, ophthalmia neonatorum. Correct answer is C. The reason there is no vaccine is the high-yield immunology point in. Gonorrhoeae undergoes antigenic variation of its pili and surface proteins, constantly changing its surface antigens to evade the immune response, which also explains why infection does not confer lasting immunity. Reinfection is common. Unlike in meningitis, gonococcus lacks a polysaccharide capsule and has no vaccine. Treat with ceftriaxone plus coverage for co-infecting chlamydia. The intracellular gram-negative diplococci causing urethritis with antigenic pili variation preventing a vaccine is Neisseria gonorrhoeae. Which set of actions is correct? A physiologist studies the three hormones that regulate calcium and phosphate. Read the command. Which set of actions is correct? PTH core, CAR, phosphate, vitamin D core, COR, and phosphate, calcitonin core, COR. Three hormones regulate calcium and phosphate. Parathyroid hormone, PHA raises serum calcium via bone resorption, increased renal calcium reabsorption, and stimulation of vitamin D activation, while lowering serum phosphate it is phosphaturic. Vitamin D calcitriol raises both calcium and phosphate primarily by increasing their absorption from the gut. Calcitonin from thyroid C cells lowers calcium by inhibiting osteoclasts. Calcitonin tones down calcium, though its physiologic role in humans is minor. Correct answer is C. The distinguishing signatures: PTH raises calcium but lowers phosphate. The phosphaturic effect dominates, whereas vitamin D raises BOTH. This difference helps interpret calcium phosphate labs. Calcitonin opposes PTH by lowering calcium used pharmacologically in hypercalcemia and Paget disease. The PTH raise calcium, lower phosphate, vitamin D raise both, and calcitonin lower calcium actions are the correct set. What is the diagnosis, the neurotransmitter deficit, and the basic treatment principle? A 68-year-old man presents with a resting pill rolling tremor, rigidity, cogwheel, bradykinesia, slow movement, a shuffling gait, and a masked facial expression. Symptoms began on one side. Pathology shows loss of dopaminergic neurons in the substantia nigra, pars compacta, with intracytoplasmic eosinophilic inclusions, LEY bodies containing alpha-synuclein. Read the command. Diagnosis, neurotransmitter, treatment principle, resting tremor, rigidity, bradykinesia, substantia, negrodopamine loss, Lewy bodies, Parkinson disease, dopamine deficiency, levodopa. This is Parkinson's disease. The pathology is degeneration of the dopaminergic neurons of the substantia nigra pars compacta, which normally supply dopamine to the basal ganglia, the nigrostriatal pathway, to facilitate movement. The histologic hallmark is the Lewy body, an eosinophilic intracytoplasmic inclusion of aggregated alpha-synuclein. The resulting dopamine deficiency produces the cardinal motor signs, remembered as TRAP, resting tremor pill rolling, rigidity cogwheel, akinesia, bradykinesia, and postural instability, plus a shuffling gait and mask faces. The correct answer is D. The treatment principle follows directly from the deficit. INC reads dopaminergic activity. Levodopa, the dopamine precursor that crosses the blood-brain barrier, combined with carbidopa, which blocks peripheral conversion, reducing side effects, is the mainstay. Dopamine agonists, MAO-B inhibitors, and COMT inhibitors are also used. Contrast with Huntington disease, EXCE. The substantia nigra dopaminergic neuron loss with Lewy bodies causing dopamine deficiency, treated by restoring dopamine, is Parkinson's disease. What is this syndrome? The structure compressed, and why is it an emergency? A 50-year-old man with a large central lumbar disc herniation presents with severe low back pain, bilateral leg weakness, saddle anesthesia, numbness of the perineum inner thighs, urinary retention with overflow incontinence, and decreased rectal tone. Read the command, syndrome, structure, why emergency. Saddle anesthesia, urinary retention, decreased rectal tone, leg weakness, cauda equina, syndrome, surgical emergency. This is cauda equina syndrome. Below the end of the spinal cord, around L1, L2, the spinal canal contains the bundle of lumbosacral nerve roots called the cauda equina horse's tail. A large central disc herniation, tumor, or other mass can campus these roots. Because these are peripheral nerve roots, lower motor neurons, the signs are LMN. The classic features are saddle anesthesia, numbness over the perineum, buttocks and inner thighs, bladder and bowel dysfunction, urinary retention with overflow incontinence, decreased rectal tone fecal incontinence, and bilateral lower extremity weakness with reduced reflexes. The correct answer is E. The reason it is a surgical emergency is that prolonged compression of the nerve roots, especially those controlling the bladder and bowel sacral roots, can cause permanent loss of bladder, bowel, and sexual function if not decompressed urgently. So the new onset of urinary retention, saddle anesthesia, and reduced rectal tone with back pain demands immediate MRI and surgical decompression. The compression of the lumbosacral nerve roots causing saddle anesthesia and bladder bowel dysfunction requiring emergency decompression is cauda equina syndrome. Which concepts are these? A behavioral scientist studies learning. In one experiment, a dog salivates to a bell that has been repeatedly paired with food. In another, a rat presses a lever more, often because pressing delivers a food pellet, and a child stops the behavior because it leads to a timeout. Read the command. Which concepts? Doggo bell, classical conditioning, rat lever and child timeout, operant conditioning, reinforcement, punishment. These illustrate the two basic forms of learning. Classical Pavlovian conditioning is learning by association, a previously neutral stimulus. The bell becomes a conditioned stimulus by being repeatedly paired with an unconditioned stimulus food, so it eventually elicits the response salivation on its own. The behavior is reflexive involuntary. Operant conditioning is learning by consequences. A voluntary behavior is shaped by what follows it. The rat presses the lever more because it is reinforced with food. Positive reinforcement increases behavior, and the child stops a behavior because of a punishment, timeout, which decreases behavior. The correct answer is A. The distinction, classical conditioning, pairs stimuli to produce an involuntary response. Think Pavlov's dogs. Operant conditioning uses consequences to shape voluntary behavior. In operant terms, reinforcement positive quote, adding a reward, negative removing an aversive, I increases a behavior, while punishment decreases it. Variable ratio reinforcement schedules like gambling are most resistant to extinction. The classical bell-food association and operant lever time out consequences conditioning concepts are the answer. What is the effect of an uncoupler like 2-phosphor-4-DNP, and how does it differ from an electron transport chain inhibitor, e.g. cyanide? A biochemistry student studies oxidative phosphorylation. Various toxins act on the electron transport chain. One agent, 2-phosphor-4-dinitrophenol, makes the inner mitochondrial membrane leaky to protons, dissipating the proton gradient. Read the command, effect of an uncoupler versus a chain inhibitor. Uncoupler dissipates gradient, electron transport continues. Little ATP heat inhibitor stops electron flow entirely. Oxidative phosphorylation couples electron transport, which pumps protons to build a gradient, to ATP synthesis, ATP synthase using that gradient. An uncoupler like 2,4-dinitrophenol makes the inner mitochondrial membrane leaky to protons, so the proton gradient is dissipated. As a result, the electrons can keep flowing. Electron transport continues or even speeds up, trying to rebuild the gradient, and oxygen is still consumed. But ATP synthase cannot harness the gradient, so LITL ATP is made. The energy of the proton gradient is released as heat instead. The correct answer is B. The contrast with the chain inhibitor is key. Cyanide, carbon monoxide, rotenone, and antimycin block electron transport directly, so electrons stop flowing, no protons are pumped, no gradient forms, and no ATP is made, and oxygen consumption falls. An uncoupler does the opposite to electron flow. It keeps flowing, but still abolishes ATP synthesis by leaking away the gradient. Brown fat uses the natural uncoupler thermogenin, UCP1, to generate heat. The uncoupler dissipating the gradient heat, continued electron transport, little ATP versus the chain inhibitor stopping electron flow entirely is the distinction. What is the diagnosis and the two pathologic hallmarks? A 72-year-old woman has progressive memory loss over years, starting with short-term memory, then language and visual spatial decline, and eventually loss of function. Brain shows cortical atrophy, especially hippocampus, with extracellular amyloid beta plaques and intracellular neurofibrillary tangles of hyperphosphorylated tau protein. Read the command, diagnosis, and two hallmarks. Progressive memory loss, cortical hippocampal atrophy, amyloid beta plaques, tau tangles, Alzheimer's disease. This is Alzheimer's disease, the most common cause of dementia. It presents as a slowly progressive decline, classically beginning with short T-term memory loss, then progressing to language, visuospatial, and executive deficits, and ultimately global loss of function. Imaging shows cortical atrophy, especially of the hippocampus and temporal lobes. The two pathologic hallmarks are extracellular beta, amyloid senile, neurotic plaques aggregates of amyloid beta from abnormal cleavage of amyloid precursor protein, and intracellular neurofibrillary tangles of hyperphosphorylated tau protein. The correct answer is A. The two hallmarks are the key facts. Beta amyloid plaques are extracellular, and the tau neurofibrillary tangles are intracellular. Risk factors include age, the ApoE4 allele, sporadic, and Down syndrome. The APP gene is on chromosome 21, causing early Alzheimer. There is also a reduction in acetylcholine, which is why cholinesterase inhibitors, donepezil. The progressive memory-led dementia with extracellular amyloid plaques and intracellular tau tangles is Alzheimer's disease. What does an elevated osmolar gap with a high anion gap metabolic acidosis suggest, and which toxins are classic? An intoxicated patient presents with an anion gap metabolic acidosis. The team calculates the OS-molar gap, measured serum osmolality minus calculated osmolality, and finds it markedly elevated. Read the command, what an elevated osmolar gap suggests in classic toxins. Toxic alcohols, methanol and ethylene glycol, fomepizole. The OS-molar gap is the difference between the measured serum osmolality and the calculated osmolality from sodium, glucose, and beyond. A markedly elevated osmolar gap means there is an measured osmotically active substance in the blood. When this is combined with a high anion gap metabolic acidosis, the classic culprits are the toxic alcohols methanol and ethylene glycol. These are osmotically active, raising the osmolar gap, and are metabolized to toxic acids, causing the anion gap acidosis. The correct answer is E. The specific toxicities distinguish them. Methanol, in windshield fluid, moonshine, is metabolized to formic acid, causing OPTIL-IFE, nerve damage, and blindness. Ethyl-ylene glycol, antifreeze, is metabolized to oxalic acid, forming calcium oxalate crystals that cause acute renal failure and hypocalcemia. Both are treated with fompizole, an alcohol dehydrogenase inhibitor that blocks formation of the toxic metabolites or ethanol, plus dialysis. The elevated osmolar gap with anion gap acidosis pointing to methanol and ethylene glycol treated with fompizole is the answer. Which describes apoptosis versus necrosis. A pathologist compares two modes of cell death. In one, a single cell shrinks, its chromatin condenses, it fragments into membrane-bound apoptotic bodies that are clear without inflammation, and the process is ATP-dependent and regulated ECaspases. In the other, a group of cells swell, the membrane ruptures, contents spill out, and there is ion inflammation. Read the command, which is apoptosis versus necrosis. First, shrink, apoptotic bodies, no inflammation, caspases, apoptosis. Second, swelling, rupture, inflammation, necrosis. The first description is apoptosis. Program, regulated cell death. Individual cells shrink, the chromatin condenses, pycnoses, and fragments, and the cell breaks into membrane-bound, apoptotic bodies that are neatly phagocytosed WIL, triggering eye inflammation. It is an ACTIFP, dependent process, executed by caspases via intrinsic mitochondrial BCL2 family or extrinsic mitochondrial BCL2 family or extrinsic death receptor fast pathways. The second description is anecirrhosis, uncontrolled cell death from injury, ischemia, toxins. Cells swell, the membrane putures, and the spilled intracellular contents incite inflammation. The correct answer is D. The key contrasts: apoptosis is programmed, affects single cells, is ATP recurring, caspase mediated, and does not cause inflammation. Membrane stays intact until cleanup. Necrosis is unregulated, affects groups of cells, involves cell swelling and membrane rupture, and does cause inflammation from the released contents. Apoptosis is clean and quiet. Necrosis is messy and inflammatory. The apoptosis, shrinkage, apoptotic bodies, caspases, no inflammation versus necrosis, swelling, rupture, inflammation distinction is the answer. Which pairing of antifungal class and mechanism is correct? A patient with invasive fungal infection is treated with antifungal drugs that target the fungal cell membrane or wall. Read the command. Which antifungal pairing is correct? Amphotericin nystatin bind ergosterol, pores, azoles inhibit ergosterol synthesis, echinocandins inhibit beta-glucan. Antifungals target structures unique to fungi, chiefly ergosterol, the fungal membrane sterol, and the cell wall. Amphotericin B and nystatin are polyenes that bind ergosterol directly, forming pores in the fungal membrane that leak ions and kill the cell. Amphotericin is broad and potent but toxic nephrotoxicity, infusion-related fever chills. The azoles fluconazole, itraconazole, voriconazole, ketoconazole inhibit ergosterol synthesis by blocking lanosterol, 14-alpha-demethylase, a fungal P450 enzyme. The echinocandins, caspofungin, mycofungin inhibit synthesis of beta-glucan, a component of the fungal cell wall. The correct answer is D. So two classes hit the same target, ergosterol, differently. Polyenes amphotericin bend existing ergosterol to make pores, while azoles bielose-CoA ergosterol synthesis. The echinocandins are distinct, targeting the cell, wall beta-glucan. Other agents, flucytosine disrupts fungal DNA RNA, and terbinafine inhibits squalene epoxidase, also in the ergosterol pathway. For dermatophytes N-PITC, ND-CoA. The amphotericin binds ergosterol, azole inhibits ergosterol synthesis, and echinocandin inhibits Beta-glucan pairings are correct. Which organism is responsible and the mechanism of the anemia? A child in a rural area who walks barefoot develops an itchy rash on the feet, then later iron deficiency anemia, fatigue, and abdominal pain. Stool shows eggs. The parasite's larvae penetrate the skin of the feet, migrate to the lungs, are coughed up and swallowed, then attach to the small intestine and suck blood. Read the command, organism and mechanism of anemia. Barefoot, foot rush, iron deficiency anemia, skin penetrating larvae, gut blood sucking, hookworm. This is hookworm, Ancylostoma duodenale or Necator americanus. The infective larvae live in soil and penetrate the skin, classically of bare feet, causing a pruritic rash ground itch. They then migrate through the bloodstream to the lungs, are coughed up and swallowed, and mature in the small intestine, where the adult worms attach to the mucosa and suck blood. The chronic intestinal bloat, lost from many feeding worms, depletes iron over time, causing a microcytic iron deficiency anemia, the hallmark complication. The correct answer is E. The signature is the combination of skin entry through bare feet, the lung migration, and chronic GI blood loss causing iron deficiency anemia, a major cause of anemia in the developing world. This skin penetration, then lung migration life cycle is shared with strongyloids and ascaris, though ascaris is acquired by ingestion. Treat hookworm with albendazole or mebendazole, plus iron repletion. The skin penetrating larvae and blood sucking gut adults causing iron deficiency anemia identify hookworm. Which statements about active versus passive immunity are correct? A patient who steps on a rusty nail receives tetanus, immune globulin preformed antibodies for immediate protection, and the tetanus toxoid vaccine to build long-term immunity. A newborn is protected in the first months of life by maternal IgG that cross the placenta. Read the command, which statements are correct? Passive preformed antibodies, rapid, short, no memory, active, own response vaccine, slow, long memory. The distinction is between receiving antibodies versus making your own. Passive immunity is the transfer of preformed antibodies from another source. Examples include tetanus or rabies, IMMU, globulin, maternal Ig crossing the placenta, and EGA in breast milk. It provides rapid, immediate protection, but is short-lived. Immediate protection, but is short-lived. The antibodies degrade and creates no immunologic memory. ACTV immunity is the host ON immune response generated by natural eye infection or by vaccination. It has a slower onset, it takes time to mount a response, but is long-lasting and creates memory cells for a rapid future response. The correct answer is D. This is why the rusty nail patient gets BOTCH, passive immune globulin for immune-mediated protection, while active immunity has not yet developed, plus the toxoid vaccine to build lasting active immunity. The maternal IgG and breast milk IgA are natural passive immunity protecting the newborn until its own immune system matures. The passive transferred antibodies, rapid but short, no memory, versus active own response vaccine, slower but lasting, with memory, immunity statements are correct. Block 24 is done. Let's review the 5 biggest traps from this block. Trap 1. In tetralogy of Fallot, squatting increases systemic vascular resistance, which reduces the right to left shunt and forces more blood to the lungs, relieving the cyanotic death spell. Trap 2. Gastric ulcer pain is greater with food and can be malignant, so biopsy it. Duodenal ulcer pain decreases with food, recurs at night, and is essentially always benign. Trap 3. Myelodysplastic syndrome causes cytopenias despite a hypercellular dysplastic marrow. Ineffective hematopoiesis with under 20% blast that can transform to AML. Aplastic anemia has an empty marrow. Trap 4. An uncoupler dissipates the proton gradient, so electron transport continues but makes heat instead of ATP. A chain inhibitor like cyanide stops electron flow entirely. Opposite effects on electron transport. Trap 5. An elevated osmolar gap with an anion gap metabolic acidosis points to toxic alcohols. Methanol causing blindness. Ethylene glycol causing oxalate crystals and renal failure. Treat with fomepizole. 24 blocks. 480 questions. Train process, not memorization. StepLogic. Learn how to think, not memorize.